Welcome to Health System CIO's interview with Jeremy Meller, CIO at Children's Healthcare of Atlanta. I'm Anthony Guerra, founder and editor-in-chief. Jeremy, thanks for joining me.
You bet, Anthony. Thanks so much for the invite.
All right, great. You want to start off by telling me a little bit about your organization and your role?
Sure, yeah. I am with Children's Healthcare of Atlanta. I've been with Children's for about 12 years. I've been the CIO since 2000. Children's Healthcare of Atlanta is one of the busiest freestanding pediatric organizations in the country. We have 3 hospitals, around 800 beds, about 20 locations, and about 15,000 employees. And we've recently just opened the Arthur M. Blank Pediatric Hospital, which is a 19-story, 2 million square foot, $2 billion new facility here in Atlanta, and we're really excited about it.
Wow, excellent. About how long has that been in the works? That whole when it started, so or whatever you
Right.
consider a start of the whole
Yeah,
project.
well, I mean, obviously the concept is probably about 10 years old.
Mm-hmm.
We had a tract of property. We had about 16 one-story buildings on it, which was our administrative campus. We then spent the next several years purchasing land and businesses all around that to expand that footprint. We then built a 2-building administrative center, which in a conference center, which we called the support center. So then we were able to move everybody out of those buildings. And then we broke ground in early 2000, right when the pandemic started. We broke ground and started building our new hospital.
So early 2020, is it?
Early 2020. Yep.
Okay.
So,
All
so
right.
yeah, about 4.5 years of actual construction. We had about 10,000 people involved in the construction, as you might imagine. Had to do it, started right during the beginning of the pandemic. So it was challenging, but we actually brought it in. We opened it about 6 months early in comparison to the original schedule.
Very exciting. Very cool. All right.
Mhm.
So I think you said 9/29 I have down here when it opens, September 29th. So very recent. And I believe there's a number of technologies that you're utilizing there. So if you want to just start off wherever you'd like and just tell us maybe some of the things that you're featuring there that you put in place.
Sure. Well, one of the first things we did was we said, okay, what are some of the biggest challenges that we're going to have? And one of the things with modern facility design, and you'll see this, is just about all new hospitals that open these days have, even in their intensive care units, have private rooms. And private rooms that are a little bit more expansive, have more rooms for family and visitors, et cetera. And what that ends up doing is really blowing out the size of your facility. So that's how we got to a 2 million square foot facility. Our hospital is the same size as Mercedes-Benz Stadium here in town, from a square footage perspective. So that's great from a family experience perspective, but it's not great in terms of time and efficiency of moving around the hospital. So one of the first things we learned and I guess identified was that the facility size was going to be an issue, and we were going to have to find ways to save steps, both physical steps and process steps, in order to help our clinicians maintain their efficiency. And so there's a group of technologies that we implemented behind that. Then the next was the fact that we're going to have and continue to have among the most complex patients in the region and in the entire country. And so with the amount of patient complexity comes just overwhelming amounts of information. And so we said, okay, we have to do something about how information is managed. How can AI be used, for example, to help our clinicians make better informed decisions? And then certainly there's been no stopping the increase in consumer expectations, the ability to have self-service as much as possible, to be provided information in real time, and all of that kind of coming together in the patient experience was the third pillar of where we really wanted to focus in order to make a meaningful difference. So all the technologies that we implemented we're really, for the most part, focused around those three categories.
Right, very good. So you started with the pillars, and then you went from there to the technologies that fall underneath. I have a list of some that you're utilizing, and if we can take them one at a time and talk about which bucket they go in. So we've got
Sure.
robots, right? We got location awareness, AI, patient engagement, video, and mobility. Um, let's delve into a little bit about that size issue. You know, a
Sure.
huge facility. So you're saying getting around is it could take a lot of time. So what can we do to save people from having to go? Well, keep moving around the facility. And there you got probably robots and location awareness fall under there. But that's an interesting approach you took. So tell me if
Yeah.
to go into the robos location awareness. We'll go from there.
Sure. Yeah. So, I mean, what you kind of have to do then is you have to map some foundational services to where they could kind of lead in terms of capabilities. So, for example, having a really good wireless network that can handle a lot of load and performance, and having, nurses and clinicians equipped with mobile smart devices. Those two things together enable a lot of mobility. And it enables, for example, a nurse to on the go to be able to do then what we did next was a really deep device integration. And so we have about 1,500 monitors and medical devices in our environment that are deeply integrated now. They hadn't been in the past. And historically, you kind of have in the healthcare world, you have, well, I mean, in most of industry, you have IT and OT. OT being those things that are a little bit more either mechanical, working a little bit more in the physical world, but often they are also IT, is what I would argue in many cases, and that's how a lot of medical equipment is, whether it be scanners, MRIs, vents, or in-room patient monitors. There's a lot of information on those that can be used uh, uh, in more meaningful ways than just as a device. And so we're taking that, we're bringing that into our network, and now our nurses, for example, on the go are able to see on their mobile device when they get an alert, and we know that better than 90% of nurse alerts are false alarms, they're actually able to see the waveforms. So they can see, for example, that a lead is disconnected,
Yeah.
and that can save steps. Then if they're in the next room over and they're in the middle of a complex medication administration, they're able to then prioritize. They don't have to create an unsafe event by stopping that action and addressing something that doesn't necessarily need to be addressed. So that's an example of how we're kind of using the technologies together. Then you layer in things like location awareness. So location awareness is of course your RTLS system, your real-time location system with monitors and sensors throughout your organization. But then we added location awareness for staff as well. So all of the staff wear badges that have a button on them. They serve a couple purposes. One is in the world we live in, the staff are very interested in this, their staff duress. So if they push the button several times, security gets alerted to their exact location, and security can respond immediately. And so that's something that our staff really enjoy. We've had better than that. We're really worried about staff acceptance. Were they going to, say, "Oh, you're just tracking me. I don't want to accept it." But we found better than 90% adoption of these badges among our clinicians because they want that security feature. So then what we get with that is we can understand where the clinician is. So for example, when a nurse walks into a room, there's a halo light, there's a board on the outside that has information about the patient. There's what we call a halo light that lights up green, and you can look down the hall and you can see which rooms a nurse is in. And there's a different color for a physician. So you may have a physician on the unit, and just with a glance, you can see where the physician may be or what room that physician may be in. So that's another example of something that can kind of save steps, whether it's physical steps or process steps. That's our goal: is how can we save steps? How can we use this? And that same location information is used in a number of different ways. On the patient engagement side, then the patient can see on the displays, and there's two displays for the patient. There's actually another screen for the parent. The parent has their own TV in the parents' area of the room, but there is a main kind of traditional television display. Then there's a patient information board that's next to it that replaces your whiteboard, but it's a smart whiteboard. And on both of those, when people enter the room, it tells the parent or the patient and family who has entered the room.
That's some really cool stuff. I love the lights and the
Yeah,
changing color of the lights and all that. That's great. Um, let's talk a little bit about, people are trying to work with these technologies in existing hospitals. I'm sure you're, in addition to you implementing these things in your new construction, you're probably implementing them to some degree in your existing facilities. So what's the difference there in terms of your ability to do things maybe quickly or do things in certain ways? In what way does a new construction opportunity allow you to do things differently?
great question. I'm actually going to weave in a little bit of information about the robots into this as well, because it's very much related. So we have 90 robots in our hospital. We are told by our vendor, who's the biggest producer of hospital robots, that we have the more robots than anybody in the world. And we actually have 9 elevators just dedicated to robots. So if you don't, and then on every floor around those elevators are staging areas for the robots. You go down to the basement, there's storage and recharge areas for robots. There's areas where the robots go through and get cleaned, or the carts get cleaned from the robots. And there's areas in food services, in pharmacy, in laboratory for the robots to sit, to be staged, to be loaded, to be sent up to the floors. And so clearly that would be very challenging, I think, in an existing facility to build that out. Where would you get the space for that? But this was from the ground up a facility that was built for robots, in addition to humans. And that is already providing great benefit. We're able to speed the time to delivery, consistency of service, etc. So a new facility, again, kind of gives you some of those capabilities. It's not all positive. When we started planning this facility, the technology landscape changes quickly. And we thought, all right, we were going to have to accommodate, and we seriously thought this, self-driving cars and drones dropping off supplies. And these were the things that we thought we needed to plan around. And it's just interesting because some of those things haven't really quite come to fruition yet. But there's other things like AI and video combined with AI and other types of things which have progressed faster than maybe we had anticipated a few years ago. So there certainly have been some limitations, but some of our big bets, are things that we were able to do that we otherwise wouldn't have been able to.
You bring up a great point. It makes me think of like sometimes devices, equipment that people make. Sometimes you put something into it and it doesn't have as long a shelf life as you thought. Now, for example, a USB charger, the original ones, the big square rectangles, they're still nice treadmills at the gym, seats in airplanes or whatever, different places where the device, the piece of equipment is far outliving the technology within it because nobody uses that particular port anymore. That's a small example of, I think, what you're talking about. So it's an interesting challenge from a technologist point of view in this involved in this type of construction. Where are we placing our chips, right? Where are we making
Right.
bets? And where do I'm not comfortable enough to make a bet. So how do I build in flexibility? How do I make some sort of space where instead of having a fixed port, for example, to back to my analogy,
Right.
that it's interchangeable as times change. And it could the equipment can continue to function, even though I think this nook and cranny is going to change pretty quickly. So more thoughts around that?
Yeah, no, I think you're spot on. And, there are a few, because the other thing we really look at is, all right, is this a technology that is maturing fast or not? Or is it really kind of established a place of maturity? And, the actual video camera itself, for example, is a pretty mature technology. And, now what you do with the video output is pretty dynamic, and there's a lot of things you can do with it. So, we were less concerned. We said, we just want to buy a really good pan tilt zoom camera. And
Mhm.
at first we thought, all right, well, this is and this was actually a late ad. This was like $1 million ad to the whole deal, and so that was a bit of an issue. And then of course you have people who are like, well, why don't you just, you can get these pan tilt zoom cameras on Amazon for about $280. That should probably solve your problem. But then when you actually do the actual bake off between all the manufacturers, you find that you really have to pay, but you also find that there's been low change over the last 10 years in these cameras, the actual
Mhm.
camera itself. Now, what you
Mhm.
do with it, again, what you do with that video feed, you can do a lot of things with. And so there were a number of cases where we said, look, we just want to get the technology in. We're not going to have all the use cases that we know that we're going to be able to do. And there's also going to be limitations on the amount of change that the organization can absorb. That's another important element I really wanted to talk about, because we had to say, look, for example, we knew with the cameras, we started with two use cases. The cameras in the rooms, they turn away when they're not in use. When you call into the room, it'll appear on the television, and the patient or parent can answer it with the pillow speaker. Now there's an override function. If, for example, there was an emergency, we just need to kind of get in and see in the room. That's also a function and capability. But we said we're going to go live with two use cases. We went live with remote interpreters. So if you and we have obviously a lot of patients who speak a number of different languages, and so we wired in our interpretive services through that. So that runs through there, and remote family conferencing. So let's say you have a family member, or grandma or grandpa lives across the country, you can bring them into the room with a really good, nice experience
Mhm.
as well. And so those were the two we started with. Now everybody asks, well, what about uh, remote sitting? What about remote nursing? What about remote consults? Those are all things that we know that we can do, in addition to some of the AI things you can do. You could actually manage and help manage and understand patient movement, motility, etc., with AI now. But we knew all those things were things that we would probably do. But to get the operational leadership really bought in that we weren't going to completely change the world day one, we had to agree to a little bit of more of a limited, scope.
Very interesting. Can you talk a little bit about how I'm assuming you leverage some type of governance to find out what the clinicians and the different users where they really wanted their lives improved, or what would, for example, if you could have three things changed about that where technology might impact your workflow, and the nurse would go, oh, and you hear from 80%, they all, this
Right,
one thing bothers all of them. And oh yeah, you say I'm the CIO and I know stuff and I know there's something for that. And I know that
right.
we could probably, so matching up clinician needs with your initiatives, it takes a lot of governance, usually pretty formal. Can you tell me how that may have factored into the decisions you made about where to focus?
Sure. Yeah. I mean, that was infused throughout. It started, we had some engagements with some hospital planning folks that would really help us understand what were, because, one of the things we wanted to do was what was the latest and greatest, what were some of the new things that were actually happening. And you can kind of see that there's a number of these things which are happening increasingly. Every new facility that opens now seems to have some more of this patient engagement technology. Some of them, not all of them, have some of the robots. That's a pretty big decision and a pretty big investment. But there's other things that are that seem to be just happening. This is the best practice. For example, one thing I think about is the fact that almost all hospitals now that are new have a basically what looks, a panel on the door on the wall outside that is like a two-way box. You can open it from the outside. You can put meds or supplies or a meal in there, you can shut it, and then it can be open from the other side so that you're not necessarily having to go into the room and disturb the patient when they might be sleeping or at odd hours, but you can still get supplies or something else into the room. And so there are a number of those kind of things that we just said, look, those are best practices. Let's just take those. It's easy to put those in. Then there was, okay, what do we want to do from the facility size? What do we think about in terms of patient complexity? One of the things we did was we built out what we called the cardboard city. It was 100,000 square foot warehouse that we filled with cardboard walls that were movable. So we actually modeled out all of our different types of units. Then we brought all sorts of medical equipment in there. Now we didn't bring an MRI in there, but we did make a big cardboard MRI. We brought all our monitors in there, our ECMO machines, our other types of machines. And what we discovered in some cases, I mean, it was everything from where the plugs were located on the walls to how the doors were positioned, or that, this room actually needs to be twice as big. It technically fits everything, but you can't also fit 12 people in here. And it was those sorts of things that we went through. So that had a huge impact on the design. And then we got to, okay, what were the process improvements that we wanted to make? And what do those look like? And we had a pretty extensive, process to try to balance what are those things that are like I mentioned before. All right, we think technology is going here with with self-driving cars. Is that something we have to address or not? We thought at first we were going to have to address that, and eventually we said, that's, even if that happens, we'll adjust to that. But there's some other things like, just the changing nature of healthcare, and over time, the acuity has increased, and especially in pediatrics, has just increased and increased and increased. And more patients that can be handled at home or don't need to come in the office or can be handled, or, their diseases can be better managed, don't need to become in the hospital at all. So then what you end up with is just a higher acuity in the hospital. And that's where you get to, all right, there's just going to be a lot more information that we're going to have to absorb, manage, etc. So when we think about how the human brain works, what we want to do is offload as many of those routine tasks that take up space and allow computers and automation to do those things, because they're actually very good at doing them, and reserve as much of the human capacity, the human brain capacity, to the complex decision making, judgment, and other types of activities that are really going to help result in a better outcome for the patient.
That's exactly how I think about, like, my phone and my
Yeah,
reminders app and my calendar app. I think of it as offloading,
that's
as
right.
I wanna offload as much as I can from my brain.
That's
So
right.
it's just an interesting way to put it. It sounds very accurate. As I was thinking, building a new hospital, I mean, what do they consider a shelf life for a hospital? 50 years, 100 years, 75 years? What are they thinking? And once you start thinking like that, you say, now, if I'm the technologist helping to build something that's going to have a 50 minimum year shelf life, that's like we get into like science fiction. Like, should I go watch some Star Trek? Should I? 'Cause-
Right.
right? Because you can't think that far ahead, as you said. So it's all about, you know, what about construction can't we change, right? You're not gonna
Right.
change the size of the room. It's not gonna
Right.
happen.
Right. Right.
And when
There's walls that are movable,
right.
and then there's walls that are, structural support walls. And
That's what
so
I
that's
used to
how
have
you have to
these
think about it.
conversations with my wife when we were buying a house, right? What can we change? You can't change the street, can't change the town, but you could change a lot. You can change theoretically, you're not gonna change much of the structure. So, any thoughts around that? I mean, this in terms of this planning for something that needs to be functional 50 years from now?
Yeah, I mean, it's a great question. And certainly we've placed, I mean, the most the one of the things we did, for example, is that every room is exactly the same size at our new hospital. So what we did is we said we're going to standardize, regardless of the type of patient, we're going to standardize the room size. And so I kind of like we went the other direction with it. We say, okay, you know what, we may, I mean, one of the things that does do, obviously, is it makes your facility larger. We could certainly have maybe saved a little bit of space in some ways if we didn't treat everything exactly the same. But because we did, we can very easily convert a general patient care unit to an intensive care unit or vice versa. And that's one of the things we did. We also built 4 extra floors. We have 4 floors that have nothing in them at this point, but we built all the infrastructure, of course, to be able to serve all those floors. Even interesting, infrastructure like our tube system. So in addition to the robots, we have a very complex pneumatic tube system. And the amount of pressure you have to push through a pneumatic tube system to get a tube up 19 stories is a lot. There's nothing new about pneumatic tubes. They've been around since the mid 1800s, but this is a smart, automated, has location tracking and awareness, so we can keep track of where the tubes are, and all of that as well. But all of these things we built so that we could expand, we could adjust, and we could modify in order to change whatever the mix of patients are that we end up having.
Pneumatic tubes on steroids, we'll call them.
Yep, pneumatic tubes on steroids.
Would those work, and not obviously not the sort of enhanced part of it, but would those work? I don't know if they would work in a power outage. They certainly probably work if you had some kind of ransomware cyber outage. I don't know. I mean, was there any
Everything is
thought to that
internet
kind of a
connected,
thing? Go ahead.
we had to do over 200 risk assessments on new technology. We had 60 new systems, include most of those actually being, or a number of those being facility systems, which previously hadn't been networked and connected, which are now. I mean, everything from your lights to your vent hoods on top of your grills are internet connected. And so, we had to really be careful about that. And so a lot of those things we ended up segmenting. If it didn't have a reason to be on our core network, it's not on our core network. It's on its own network, which can't get to our core network.
Mhm.
But it still has some of those features that allow it to be internet connected. But that is a huge challenge.
Yeah. Any more cybersecurity thoughts? Anything different about new construction when it comes to cyber?
Well, I mean, certainly it was an opportunity to make sure that we did things right, that we had the right kind of segmentation, that we had the right kind of physical security controls. I mean, in the olden days, we had, doors with keys and locks, and everything has got, complex security, zone security, badge access security. So from a physical security perspective, that was certainly an improvement for us. The amount of medical devices that we needed to clear. We didn't just bring things over either from because we shut down one hospital. We moved a couple hundred patients to the new hospital when we opened it up, and so we didn't just roll anything into the new hospital. We had to make sure everything was cleared. We understood it. We understood the security profile because we treated it as though it was a clean environment.
Mhm.
We also knew
Mhm.
that we were going to be a target. We were getting a lot of, and we actually did. We got several phishing attacks that were aimed at our staff. That would say things like, welcome staff to the new hospital. We need you to click here and
Wow.
update your information. And so this is the intelligence, the social engineering intelligence that's behind some of these things. But we anticipated that. And we really worked hard at training and educating our staff to stay on guard and stay alert. We are going to get, cyber attacked. We ran extra penetration tests. We increased our level of monitoring with our SOC, our Security Operations Center, and we had a physical on-site penetration at test where we hired somebody to come in before we had actually officially opened the doors, but everything was running and operational, as you might imagine, for weeks before the doors are actually opened. And they came in, they tried to plug into ports, they tried to connect through different wireless networks. They tried to do what they could do to get into our network, and we found that it was secure.
Wow.
They did find a couple of areas where that if we hadn't had one layer of protection, we might have been compromised, and those were areas we can improve upon. But overall, we were safe and secure. So that was an important part, and I think that anybody who's opening a new facility really needs to think about that because you will be a target.
That's great stuff, Jeremy. We're just about out of time. I just want to give you an opportunity for a final thought. Let's get your best piece of advice for one of your colleagues, and let's say they're just at the beginning of this journey. They've just been brought into the meeting where they're told that we're going to build a new hospital and this is going to be a long process and you're going to be involved. And
Mhm.
what's your best piece of advice navigating this journey for them?
Well, I guess, I mean, you've got to work with your colleagues who are probably going to be really overwhelmed with the amount of change, most of us and most of us CIOs are trying to move our organizations forward. And it's not that the operational teams aren't. It's that they are often just trying to get through the day and trying to get through it safely. Because if you can't provide safe care, you can't provide effective care, you won't be able to do any of those things anyway. So you have to live in both of these worlds, and you have to work with your operational partners on what we can accomplish, what the staff, and we had, a couple thousand new staff that we hired as well for the new hospital that had to be trained on everything. And then we had staff coming over, and even without the new technology, their processes and departments were changing because they had to change. And because they were organized in different ways into different departments in different locations. And so be realistic about how much can be absorbed. But I think what really worked well for us was we agreed, okay, we are going to have day one, and then we're going to have day two use cases, and we're going to be reasonable about what we put in day one, but we'll get the technology foundation established so we could do those day two things. So that's where we were able to make the heavy investments in a more robust network, in the ubiquitous location awareness across the organization, in the robots and the automation that we were able to do there, and even in some of our patient engagement and other types of technology.
Jeremy, that's wonderful. I think this is going to be very interesting and very useful for your peers when they listen. So thank you so much for your time.
Great, Anthony. Thank you. It was a pleasure.